Good afternoon. So we'll begin our clinical combined round from Pediatrics Unit 1. You've got an interesting case which will be presented by Dr. Rishika, and discussed by Dr. Tanya and Dr. Narendra Bagdi, who is my faculty colleague. So we'll begin, Rishika. So we are really, it's. I thought maybe I'll speak later, but it's great to have Dr. Gurupal Singh here. He's an institute graduate who did his MD as well from pediatrics. His primary love, as far as I know, was rheumatology, but now I think he's shifted to gastroenterology, working in Stanford. Maybe we'll have his comments later, after the session.
Right here and work on Dr. B's book.
A very good afternoon to the respected faculty and my dear colleagues. We are here to discuss a case of 5-year-old female child who presented with a multisystem inflammation. Coming to the presenting complaints, the index case is a 5-year-old girl who presented with the chief complaints of fever, right-sided weakness and erythematous rash since 7 months. There was bluish discoloration of right middle toe since 2 months. And there was no history of oral ulcers, joint swelling, joint pain or restriction of movement, no history of cough, chest pain or breathing difficulty, no history of any bleeding manifestations, no history of hematuria, swelling around the eyes, limbs, abdomen and face, no history of altered sensorium, seizures, cranial nerve palsy, and there was no history of TB contact. The child was born by full-term normal vaginal delivery with a birth weight of 2.5 kg and there were no adverse perinatal events. Developmentally, the child is appropriate for age and has immunized till 5 years as per the national immunization schedule. The child is second in birth order of a third-degree consanguineous marriage with no similar illness in the family. The child was symptomatic since August 2021 with the chief complaint of fever. After the fever, on day 4, the child developed right-sided weakness, which is gradually improving on symptomatic management and physiotherapy from the local practitioner. But however, the fever was still persisting. And the child also developed bluish discoloration of right middle toe in February 2022, for which she was taken to a local practitioner, where she was also identified to have hypertension and hence she was started on amlodipine and labetalol. However, the fever was persisting and she was also started on enoxaparin and aspirin as in view of a thrombotic event, and with the persisting fever, hypertension and bluish discoloration of right middle toe, she was referred to AIIMS New Delhi for further management. On examination at the casualty, the child is conscious coherent with the pulse rate of 1 or 2 per minute, which is synchronous and regular. However, the peripheral pulses were feeble. Respiratory rate, it is 20 per minute with the saturation maintaining 99% at room air. The BP in the right upper limb was 102/88, which is between 90 to 95th percentile on amlodipine with no significant interarm difference. Peripheries were warm with capillary refill time of less than 3 seconds and the child is afebrile. On general examination, pallor was present and there were no icterus, cyanosis, clubbing, edema or significant lymph nodes and the BMI of child is 11.3. On examination, there was also a limited type of rash on the bilateral lower limbs. We have this irregular reticular pattern of rash which is observed. On systemic examination, per abdomen, it is soft, non-tender and non-distended. Liver is 1 centimeter below the right costal margin and the spleen is 5 centimeters below the left costal margin. Bowel sounds are present with no audible bruit. However, respiratory and cardiovascular system examination was normal. And CNS examination, higher mental functions were intact with no cranial nerve deficit, sensations were intact and the motor bulk was normal with hypertonia in the right upper limb and lower limb. Power was 4/5 in the upper limb and lower limb of right side and reflexes were 3+. There were no cerebellar or meningeal signs and the skull and spine were also normal. Hence, summarizing, a 5-year-old female child with fever, rash and right-sided weakness with hypertension and organomegaly, the possibilities kept were either inflammatory disorders, infections or other conditions. In the inflammatory disorders, we have medium vessel vasculitis like polyarteritis nodosa or systemic lupus erythematosus. In infections, we have infective endocarditis or other conditions like sickle cell anemia or prothrombotic conditions. As per the possibilities kept, investigations were done in the lines of the possibilities, which reveal hemoglobin of 8.7 and 8.5 in 2 occasions, which is in the lower side. And total leukocyte count was also in the lower normal side with 4,000 LUs. Platelet were normal. Peripheral smear revealed normocytic normochromic anemia with no sickling. And other renal function test, kidney function test, liver function test, and the electrolytes were also within the normal limits. However, the inflammatory markers like CRP and ESR were elevated, and D-dimer, CPK, and LDH were within the normal limits. As SLE was kept as a possibility, ANA ANCA were done, which were negative, and the complements were also in the normal. Coagulation profile was normal with PT, INR, APTT within the normal limits. Urine protein and RBCs were nil, revealing there was no hematuria. And antivirals like HBsAg was also done, as it may be the possibility of polyarteritis nodosa, but it was negative. Prothrombotic events, APLA workup was done with, for lupus anticoagulant, anticardiolipin, and beta 2 glycoprotein, which was also negative. Factor 5 leader mutation was also negative. Other radiological findings like echo was done, which is normal biventricular and valvular function with no vegetations. USG abdomen reveals splenomegaly is present, however, there were no ischemic infarcts in the spleen. Ultrasound Doppler carotid of upper and lower limbs was done with no evidence of thrombus, and the chest X-ray was also normal. Now I call upon my colleague from radiology and pathology to further discuss the radiological findings.
Good afternoon, everyone. I am Dr. Omam, a senior resident from Radio Diagnosis Department. So these are the brain XL images. These are first three are the T2 XL, and second the last second are flare XL. So in this we could see this red arrow mark is showing a T2 hyperintense focal lesion in left half of the brainstem and involving the substantia nigra, and also in the T2XL section shows the hyperintense area in focal area in the right perisylvian white matter, while in the flare this lesion in the brainstem is showing hypointense area. This is suggestive of lacunar infarct. Next. So DSA of the patient was done, and while the left renal artery, these images are DSA images of the left renal artery, and it shows this thin arrows are showing poor opacification of the interlobar branches, and this yellow arrow, these are showing there's a small microaneurysm, multiple are seen in both the upper and lower segment. So CT angio bilateral lower limb was done. This was done after after 4 days of DSA. So this is showing multiple segmental narrowing. In this this red thin arrows are showing the narrowing, focal segmental narrowing in the bilateral external iliac arteries, and this is the angio lower limb of both the bilateral lower limb. These arrows are showing multiple focal narrowing, segmental narrowing are seen in bilateral. In right SFA, right popliteal artery, and bilateral PTA. So this according to the images, the DSA and the bilateral angio of the lower limb, there's focal segmental narrowing, and a few microaneurysms are seen in the bilateral renal artery with lacunar infarct. So most likely there's possibility of vasculitis has to be considered. Thank you.
Good afternoon, everyone. I'm Dr. Sagir. I'm SR Pathology. So I'll be discussing about the skin biopsy. This is the scanner view of the skin biopsy. It has an unremarkable epidermis. The underlying dermis, including the subcutaneous tissue, is showing perivascular lymphohistocytic infiltrate. On a higher magnification, we can see that there are a lot of lymphohistocytes around the blood vessels with few RBCs extravasation and few neutrophils. There were also some neutrophilic dust. And on the higher magnification in the papillary dermis, we have these arteries which are showing fibrin thrombi. So in the higher magnification again, we can see that many of these arteries, they are showing fibrin thrombi along with some nuclear dust and lymphohistocytic infiltrate. And epidermis was unremarkable. So we have suggested the possibility of a leukocytoclastic vasculitis with fibrin thrombus. But there was no fibrinoid necrosis of the vessel wall. Thank you.
Hence, I'm compiling the clinical presentation and the imaging findings and the skin biopsy changes. According to the EULA criteria, final classification criteria of polyarticulitis nodosa, it is fitting into this criteria. As the major criteria having aneurysm, and one out of the 5 criteria which involving skin involvement and hypertension, a probable diagnosis of polyarticulitis nodosa was made, and the child was started on treatment with steroids, and first dose of IV cyclophosphamide was given. She was also started on enoxaparin and aspirin as there was a thrombotic event after the DSA procedure, and she was also started on amlodipine for hypertension. However, however, the clinical features are not fitting into the classic criteria of polyarticulitis nodosa because the odd points are early age of onset, CNS involvement, organomegaly, and absence of thrombocytosis or leukocytosis. CNS involvement in polyarticulitis nodosa is less than 10%. So these points are not fitting into the criteria. Hence, we have thought of doing a whole exome sequencing, which revealed a pathogenic variant positive of reported phenotype was detected, which is adenosine deaminase deficiency 2, which is a monogenic variant of polyarticulitis nodosa. Hence, the final diagnosis of adenosine deaminase 2 deficiency was made, and the child was started on anti-TNF therapy bi-weekly, which is the mainstay of treatment, that is adalimumab. And the steroids were stopped gradually on tapering doses in 6 to 8 weeks. And enoxaparin and aspirin was also stopped as repeat Doppler revealed resolution of the thrombus, and the child is now maintaining normotensive records on amlodipine. Last follow-up was made in February 2023, where the child is growing well, afebrile, no rash or no residual weakness is present. And the plan is to continue adalimumab and to screen the family members, though they are asymptomatic to further mutations. Now I call upon my colleague to lead the discussion further on polyartitis nodosa and adenosine deaminase 2.
Good afternoon, everyone. Polyarteritis nodosa, on the basis of clinical features, has been classified into 2 forms, the systemic and the cutaneous form. In systemic form, we have cutaneous manifestation along with multi-organ involvement, and in cutaneous form, this clinical manifestations are primarily limited to the skin. Previously, there have been pan-like features that have been described with hepatitis B infection, but the incidence of this entity is decreasing currently. The last is the monogenic form of the pan, which is the deficiency of adenosine deaminase 2 enzyme. For our today's discussion, we'll restrict ourselves to the monogenic form of pan, that is deficiency of adenosine deaminase 2 enzyme. The DADA2 was first described in 2014, and up till now there have been nearly 300 cases that have been reported. So coming to adenosine deaminase enzyme, there are 2 isoforms of adenosine deaminase, ADA1 and ADA2. ADA1 is commonly found in lymphocytes and erythrocytes, and the deficiency of this leads to severe combined immunodeficiency, as we all know. On the other hand, ADA2, which is mainly expressed in myelocytes and lymphocytes, and the deficiency of this enzyme leads to early onset polyarteritis nodosa. After discussing the ADA enzyme, how does ADA2 enzyme acts, and how does the deficiency of adenosine deaminase 2 leads to other clinical pathogenesis? So normally in body, ADA2 converts adenosine to inosine. So in the deficiency of adenosine deaminase, there is increase in extracellular adenosine levels. The increase in adenosine levels lead to conversion of macrophages to the pro-inflammatory state, that is the M1 form, and the adenosine also leads to activation of neutrophils. The activated macrophages and the neutrophils together lead to increase in TNF alpha levels, which further leads to inflammation, endothelial activation, and vasculitis. Apart from the inflammation, ADA2 also has a growth factor effect on hematopoietic stem cells and B cells. So in DADA2, we also have manifestations of immunodeficiency. After discussing the pathogenesis, now we come to the clinical spectrum of DADA2. Like any other vasculitis, DADA2 can also affect every organ in the body, but the most striking feature that is present in DADA2 is the neurological findings in form of recurrent ischemic strokes, hemorrhagic strokes, and others. Also, cutaneous manifestations, immunodeficiencies, and hematological manifestations are far more common in DADA2. So as we have seen that there are myriad of symptoms that can occur with DADA2. These clinical findings and the clinical features depend on the type of the genotype, the type of mutation that the patient carries. If the type of mutation is the missense type, there is vasculitis like picture, and if the type of mutation is a nonsense mutation, then there are features of bone marrow failure and pure cell aplasias. So how do we differentiate that? How do we differentiate that this is DADA2 or PAN? So normally the DADA2 average age at diagnosis is nearly 5 years of age as against 9 years in childhood PAN. And the most distinct the finding or the clinical feature that differentiate it from childhood PAN is the striking involvement of CNS in nearly 60% of the patient as against 20% in childhood PAN. Apart from the neurological findings, as we have already discussed, in DADA2, there are features of bone marrow suppression and immunodeficiencies. On the other hand, childhood PAN and adult PAN usually have features of lymphocytosis, leukocytosis, and thrombocytosis. So this was a systematic review which was published in 2021, where they had taken 32 patients of childhood PAN and 18 patients of DADA2, and they had followed them for 10 years. And the key differentiating features that differentiated DADA2 from PAN were the younger age at onset, parental consanguinity, strokes, lymphopenia, and lack of thrombocytosis. Also, in terms of mortality, DADA2 patients nearly have double the mortality as compared to 1 to 4% in childhood PAN. So, more Indian literature is lacking in terms of DADA2, but the recent study that was published in 2021 for DADA2, apart from the common findings that we have already discussed, the one striking feature and differentiating and the new entity that was there was that out of the 33 confirmed cases of DADA2 in India, it was observed that nearly 50% of the cases were that of adult. So we should not restrict ourselves for the childhood forms only. We need to consider this monogenic syndrome in adults as well. Coming to the treatment implication, as we have discussed the role of TNF alpha in pathogenesis, the mainstay of treatment are the anti-TNF agents. So this was a study that was published in 2019, where they had followed patients for 733 patient months. So in the arm that had not received anti-TNF agents, the recurrence of stroke was in 37 patients, as against the other arm did not have any stroke in the patient who received anti-TNF agents. So to conclude, if there is multisystem involvement, we consider the possibility of vasculitis. Polyarteritis nodosa, as we all know, is primarily a medium vessel vasculitis which can affect children of all ages. Apart from that, if there is early age of presentation, CNS involvement, we should think of DADA2, which has got its therapeutic implication in form of role of anti-TNF agents in the treatment.
So thank you, Tanya and team, for presenting the case. So we thought to discuss this case with the House because of various reasons. Number one is, as shown by Tanya, that there is a merit of clinical presentation with which these children can present to us. And they can present to probably anyone who is providing pediatric care, right from CNS manifestations, GI manifestations, skin manifestations, or arthritis, or renal involvement. So as we have seen that there is a wide spectrum of presentation, it's important that everybody should be aware about this newly diagnosed monogenic form of PAN, which is popularly known as DADA2. That's number one. The number two message that we want to give through this particular case is that, as we have seen, that it has got a therapeutic implication in terms of differentiating this from the classic PAN, where the traditional conventional management rests on the use of a host of immunosuppressive agent. For example, we will go ahead with IV methylprednisolone, followed by cyclophosphamide or mycophenolate mofetil. In contrast, as shown by one of the slides in the seminal paper in NEGM, where they have demonstrated that the risk of stroke is practically negligible if these patients are given the standard of care, that is anti-TNF agent. So that's the therapeutic implication of differentiating DADA2 from the classic PAN that we understand. And as the knowledge about this entity is improving or increasing, it is said that around 1/4 of the patients with PAN are likely to harbor this very mutation. So it is important that we should keep an high index of suspicion whenever we are whenever you're dealing a child with polyarteritis nodosa. And the key features, once again, I would like to reiterate are: number one, young age of onset. Number two is the CNS features, as shown in this few of the slides. The striking difference is the CNS stroke, which is not there in classic PAN, and it is only less than 5%, or in some series to the tune of 10%, where they can have CNS manifestations. But if you are suspecting a vasculitis in child who's ending up with a stroke, probably the DADA2 should be high on cards. Number three is probably, apart from the classic garden variety of classic PAN, where you will be able to see the thrombocytosis, the striking neutrophilic leukocytosis that would be absent in this very entity. Also, they would also have hypogammaglobulinemia or associated immune deficiency. So these are few clinical features which will help us differentiating this from the classic PAN. Having said this, as we have seen that there is a wide spectrum clinical presentation, and that will depend on the residual enzyme activity. And in one of the slides that she has shown the underlying mutation and the clinical spectrum. So that will depend on probably the residual enzyme activity. And if the residual enzyme activity is probably null, then these patients can even present to hemato-oncologists with a pure red cell aplasia kind of picture. Or if the residual enzyme activity is there, then probably they can present with a wide spectrum of vasculitic kind of manifestations. So these are the few key messages that we would like to give through this very case. Apart from that, having said that, there are a couple of unanswered questions yet. Number one is, as we have seen that apart from pediatric population, this is also being reported in adults. So given the fact that the mutation is there right from the birth, but why they are manifesting 3 years, 4 years, 5 years down the line? I mean, there are case reports at 60 years men presenting with DADA2 deficiency. So that remains unanswered, at what triggers that inflammation at that fag end of the age. The other probably the answer which needs to be is yet not clear is the duration of immunosuppression or the anti-TNF agent that is going to be given in these kids, given the fact that it has got relapses, multiple relapses as shown, and as we have learned that probably this is more fatal, more aggressive, and the mortality is also high with DADA2. They need to be given a long-term immunosuppression, but we don't know the exact endpoint. So maybe in times to come, we may have some cues to these questions. So with this, probably I would invite the house for questions and comments. And we are happy to have Professor Gurpal Singh with us. Sir, you comment. So those who joined late, he's the alumnus from this institute, and he is currently an adjunct professor in Stanford medicine, and his primary love is, I think, what I learned from the seniors is that he's initiated pediatric rheumatology at AIIMS. Sir, your comments.
Excellent. It's an excellent presentation. That could index of suspicion high with the after you got to the point of vasculitis and PAN and figured out that with the CNS complication there's something that's going on. So I must commend you on thinking about it and continuing to investigate. Excellent.
Thank you. Thanks. Professor Rakesh, please.
The question about the use of adalimumab or the rest of tuberculosis
I think if we have missed that, I'm sorry for that. But yeah, typically what is said about adalimumab, it's an anti-TNF agent, and it has got a high risk of, the flare of the latent tuberculosis. And it is often important. In fact, I remember a couple of patients who had developed significant, I would say, pulmonary tuberculosis flare after starting that. So what we follow is we will, of course, screen all patients before starting adalimumab for latent tuberculosis through chest X-ray, MON2, and which was exactly done in this patient as well. And if it is negative, then only we go ahead with adalimumab. So if you look at the literature, people will recommend doing IGRA before starting anti-TNFs, but given the cost prohibitiveness of this, probably what? No, that's fine. So what? So what we follow is what we follow is we'll do a chest X-ray if it is normal. MON2 if it is normal, then probably we'll go ahead with IGRA just to make it cost kind of more feasible for us. And if MON2 is positive, we don't go ahead with IGRA.
Okay, fine. I think that's one. Just query about clinical exam didn't show any differential pulses and similarly no findings on ultrasound kidney during that combination.
I think we made the ultrasound finding on the kidney. The kidneys, there were there were no infarct kind of thing. The pulses were feeble, as rightly mentioned by Rishi on the lower. Yeah.
The microdotting which or in the red cell, is it the uniform feature of data of this time?
That was stroke. That was a stroke kind of feature. A stroke, yeah, yeah, yeah. So, yeah, thank you. So, fine. So usually the cost, if I roughly remember, it is around it comes in two strands, 20 mg and 40 mg. The 20 mg cost around maybe 4,000 something, and that 40 mg cost around 8,000. So in this very case, we have one of the NGO has helped us again. One of the batchmate of Professor Arvind Bagga sir, that Jeev Daya Foundation has helped us in that. And usually we start after the basic investigation that I've just mentioned. And typically we say that the disease is in remission for at least 1 to 2 years, then we think of tapering it or stopping. Yes, please.
Very interesting case. When you showed me the pathophysiology of this disease, deficiency, mainly the intermediate cells are having some part of it. So, and there are 30 dark cases actually being reported in India.
Yeah.
So, whether the treatment is same for all the 30, they have found the same treatment, what is the outcome? Second is, anybody tried a bone marrow transplantation in these cases?
Perfect question. In fact, good question, and thanks for bringing it up. So basically, as I've told that the clinical features would depend on the type of underlying mutation, and if the mutation is probably nonsense, where the enzyme activity is practically insufficient to provide the necessary fuel for the myeloproliferative cell, these patients will end up presenting with pure red cell aplasia. So in that case, the treatment of choice is hematopoietic stem cell transplant, and adalimumab or anti-TNF may not be of any use. However, on the other spectrum where there is some residual enzyme activity and they are predominantly presenting with vasculitic kind of features, in those cases probably, not probably the standard of care would be anti-TNF agents.
Thank you very much for this presentation. You will talk about not knowing when to stop adalimumab, and that's the problem with many of these conditions. I'm also wondering about the other end. When to start? Does everybody who is suspect DADA2 or document DADA2 become a candidate for adalimumab, or can we strategy?
Again, a challenging question. I don't have the right answer as I mentioned earlier, but yes, like in this very case, we are planning to screen the family, but even if we screen the family and we don't have overt clinical feature, and as reported in some of the literature that the adults at 60 years can present it, but the mutation is there right from the beginning. So I don't think that there is a point of starting the preemptive treatment, but probably that just puts us at a low threshold of detecting the disease at the earlier phase in starting the treatment.
Thank you.
Yeah. Yes, please.
So, Dr. Lalna, same case, so I think you performed whole exome sequencing. This patient, my query was, are the mutations limited and specific for talent? Is there any microarray available so that we can only look for specific mutations and that will be cheaper rather than getting the whole genome sequence?
I think as per my understanding of this is concerned, I think microarray is not the test for this. What you will do is, since the mutation is limited to a particular gene, you can target that very gene. That should be sufficient enough. But in most of the labs where you order whole clinical exome or whole exome, they eventually end up giving the whole exome. They do it like whole exome. Fine. Thank you for the question.
Thank you very much for the wonderful presentation. From the Department of Pediatric Surgery, we shall be presenting a child with bilateral AIIMS tumor. There are certain unique features in this case. Overall, let me tell you that Wilms tumor mortality has reduced almost by 50% in the last 20 years, since the time Dr. Gopal left us. And there has been a survival of children more than 90%. It's a wonderful thing which has happened. We have understood the side effects of chemotherapy. We understood what relatively adjuvant therapy vis-a-vis radiotherapy, etc., mean to these children. We have also seen their consequences. I mean, the stunted growth, the consequences of chemotherapy, what to choose first, etc. So this particular case has some very unique features. I am not going to let the cat out. So let us begin with this and we'll discuss it.
Good afternoon, everybody. I'll be presenting the clinical scenario of our patient. A 1-year-old girl child presented to our OPD with complaints of a rapidly progressing abdominal distension and a right-sided abdominal lump for the past 1 month. There was associated history of loss of appetite. There was no other significant positive history. There was no fever or pain abdomen or hematuria or any urinary retention. And there were also no similar complaints in the family. On examination, the child was active, conscious. She was pale and thin-built, and her vital data were within normal limits. Her heart rate was 96 beats per minute, and blood pressure was 92 over 48 millimeters of mercury. That is, it was within the 80th centile. And the systemic examination was normal. There was also no evidence of syndromic association of Wilms tumor, like the genitalia was normal, the eyes were normal, and there was no hemihypertrophy. On per abdomen examination, abdomen was soft and distended. There were 2 lumps noted, one on the right side of the abdomen, which was about 10 into 7 centimeters, firm, non-tender, and another similar lump was noted on the left side, which was about 4 into 3 centimeters. The child was initially evaluated at a private hospital where an ultrasound abdomen was done, which had revealed a bilateral renal mass. And later she was referred to AIIMS, and here at AIIMS we had got a contrast-enhanced CT scan of the chest and abdomen done, which was suggestive of bilateral Wilms tumor. And following the NWTS protocol, we had started the child on neoadjuvant chemotherapy. She received a 3-drug regimen consisting of vincristine, actinomycin D, and doxorubicin. She received 6 cycles of chemotherapy from 13th of January to 17th of February 2022. And a response evaluation was done by a repeat contrast enhanced CT scan, which would be discussed later on by our radiology colleagues. And at this point of time, an echocardiography was also done to look for any evidence of cardiotoxicity. We do it as a protocol after giving doxorubicin. So echo at this point of time was normal. And in view of non-response of the tumor, that is, the tumor had not significantly decreased in size. So because of that, a decision was made to conduct an open renal biopsy, which was done on 1st April. And child had received further 6 cycles of chemotherapy. The biopsy report had revealed that there was no evidence of anaplasia, and hence we had continued with the same chemotherapy. And she received further 6 cycles till 12th of May 2022. And the tumor remained stable in size even after 12 weeks of chemotherapy. I will now request Dr. Omen from radiology to discuss the CT findings.
So I'll be discussing some serial CT, both abdomen and thorax. So this was the first CT, which was done in January 13. So in this we can see there's bilateral large heterogeneously enhancing renal masses. You can make out the renal cortex in the lower pole on both sides. So the right renal mass is abutting the liver's right inferior lobe of the liver, and it is laterally and abutting the abdominal wall and slightly closing the midline. However, showing the fat planes are maintained with the aorta and IVC, and no obvious tumor thrombus could be made out in the IVC. So the thorax X-ray sections is showing bilateral clear lung fields. There's no evidence of any focal lesion. So this is done in March, I think, after the chemotherapy. So in this, there's the bilateral renal mass are both are still seen, and there's no significant interval change in the size and the extent of the renal mass. And even in the thorax, there was no interval change. So this was done in the in May. So here, there's bilateral renal mass, but however, still there's no it showed the mild increase in size and extent, but the increase was less than 20%. It's a stable disease, and in this scan, the mass is focally netting over the IVC and it's compressing on it. Just wait, but there's encasement of the IVC, so it can be due to the compression of the mass, or there can be tumor thrombus. So in CT thorax, this shows in left lower lobe, there's a patchy area of consolidation and fibrotic bends in the left lower lobe. And there's a focal segmental air trapping. This was not seen in the previous scan. Can be likely infective etiology. So these are the comparison of the three serial scan. This is the first one is the January scan. This is the March scan, and this is the May scan. So there's no significant interval change in the sizes of the lesion. However, there's morphologically, there's the first scan shows there's heterogeneously enhancing, and this is slightly hypoenhancing. And in the third scan, there's multiple cystic area development is seen. And in first and the second scan, we can make out the IVC. There's no tumor thrombus seen. And in the third one, there's a focal indentation, but there's a compression of the IVC. So this is a post-op scan, and in the post-op scan, there was no residual mass seen in the bilateral post-op bed. And this is the thorax scan. The previous patchy consolidation in the left lower lobe has decreased. So most likely that was an infective etiology.
After the repeat CT scan following chemotherapy, there was no significant decrease in size of the tumor. But still, as per protocol, there is no added advantage of giving chemotherapy beyond 12 weeks, and hence we had planned for surgical excision of the bilateral tumor in a single setting. Preoperative investigations, the hemogram and renal function tests were done, which was normal. BP recordings were high for this child. It was 117/86, that is, it was more than the 95th centile. And cardiac evaluation had revealed severe LV dysfunction, which would further be elaborated by Dr. Nabil from Pediatric Cardiology.
Good afternoon. This child, when evaluated from our side before the chemotherapy, this child was having a normal echo with a normal ejection fraction. Child didn't have any symptoms of frank heart failure during presentation, or there was no past history of heart failure also. So, and on evaluation, the child had tachycardia, S3 gallop with hepatomegaly, and an echo was done which showed LV ejection fraction of around 15 to 20% with a small LV clot at the apex. So after ruling out other structural causes for LV dysfunction and arrhythmia, we made out the diagnosis of anthracycline induced cardiotoxicity, considering the history and previous normal echo, and then acquiring the LV dysfunction later on. And also the child was noted to have hypertension also. And the important problem in our ahead was like the child was planned for surgical excision of tumor after 12 cycles of chemotherapy. So which was the surgery was of utmost importance. Regarding anthracycline cardiotoxicity, this child has specifically risk factors were female gender, age less than 5 years, and hypertension. And although the dose received is high for the child, it can cumulative dose was nearly 100 milligram per meter square, which has which the child has received. That part was not very much high risk. But even though studies have reported that even in a lower dose, children can have a significant cardiotoxicity, which is explained by most of the time some genetic underlying causes where the child can develop cardiotoxicity. So, and especially pediatric patients have a higher risk for developing cardiac toxicity. So when we are giving chemotherapy with anthracyclines, so what is the timeline of development of cardiotoxicity? During the start of chemotherapy, there are several ways where we can prevent development of cardiotoxicity by limiting the anthracycline dosage, using the continuous infusion or analogs of anthracyclines, or using liposomal forms of anthracycline. And there have been several reports, there are several studies which show that it is beneficial to give dexamethasone beta blocker, RAS inhibitors, and statins in case of while starting chemotherapy for patients going for anthracycline based chemotherapy. And in early stage, how we evaluate is by cardiac biomarkers and by global longitudinal strain by echo, where you can pick up subtle subclinical cardiotoxicity without LV dysfunction. Frank LV dysfunction will not be there, still you can pick up these things. And in asymptomatic cardiotoxicity, where there is LV dysfunction but the patient is asymptomatic, there also echocardiography can be done, and then you can start on drugs like AC inhibitors and beta blockers, which will prevent further progression of LV dysfunction. And in frank heart failure, you will have to treat the heart failure first and then go ahead with other treatment. So in this patient particularly, we had concerns of high risk of worsening heart failure, risk of thromboembolic events due to LV thrombus, and increased perioperative mortality due to severe LV dysfunction. And there is always increased risk of arrhythmia and hypotension, as there is in any patient with severe LV dysfunction, which is who is going for a major procedure. So for management part, we started on diuretics, furosemide and spironolactone was started for heart failure, and AC inhibitors, enalapril and beta blocker carvedilol was started for control of heart failure symptoms, and anticoagulation with enoxaparin was started for LV thrombus. And parents were counseled regarding the need for the surgery and as well as the high risk involved in presence of LV dysfunction and LV thrombus. And heart failure was medically controlled prior to the surgery, even though the LV ejection fraction was still the same during the surgery also. So thankfully, there was no perioperative worsening of heart failure or any arrhythmia, and on follow-up, the LV thrombus resolved and the hypertension was controlled with medications. And we recently followed up the patient, and the LV function has improved up to 30 to 35%. And the child is being continued on the medications, AC inhibitors, beta blockers, and diuretics.
So, as was described by Dr. Nabil, the patient was optimized preoperatively with oral medications, enalapril, carvedilol, alvecon, and the baseline GFR estimation was done, which was 113. That is, it was normal, and anesthesia consultation was also placed in view of high perioperative risk, and a pediatric nephrology consultation was also sought as a precautionary measure for renal failure in the postoperative period, which can occur because of transient vasospasm or other causes. I would now like to request Dr. Srinivas to address their concerns.
So once we got a call from the pediatric surgery team for such a younger child with a early onset AIIMS tumor, we would always try to consider the syndromic causes to be ruled out first. The common causes which we consider is the Dennis-Drash syndrome, the Wager syndrome, which is the AIIMS tumor, aniridia, genitourinary abnormalities, and the mental retardation, and other hemihypertrophy syndromes. So on examination, the child had a normal genitalia and the developmental age was appropriate for the child. There was no proteinuria, which could be seen in Dennis-Drash syndrome, and the hypertension was controlled with 3 antihypertensive agents. So once there was a plan made for the partial nephrectomy, that is the nephron sparing surgery for this child. The two concerns we had were, one, it could be converted to a radical nephrectomy if the margins are not very clear, or as shown in this figure, there is a high chance of occurrence of acute kidney injury post-op even in a nephron sparing surgery, where there is a 4.5 times increase in the risk of AKI when there is an associated ischemia which happens following the surgery. So prophylactically HD catheter was placed, and the other preventive measures like avoidance of nephrotoxic medications, maintenance of hemodynamic status to avoid ischemia, and frequent monitoring of the input and output were advised. Fortunately, the child underwent the surgery well, and there were no need for performing the kidney replacement therapy. And currently in follow-up, the renal function, the child had a serum creatinine of 0.3 milligram per deciliter, and the hypertension is controlled on 2 antihypertensive agents. Still, the child doesn't have any proteinuria, and ultrasound abdominal to look for any internal genitalia changes like gonadoblastoma was also normal. Plan is to follow the child with monitoring of the blood pressures and for the proteinuria. Thank you.
Dr. Rakesh sir from anesthesia would now address their concerns.
Thank you. Good afternoon. So, from the anesthesia point of view, the main challenge with the anesthesia is first thing the pediatric patients is a normal challenge, but apart from this, this child is a major surgery, right nephrectomy with left partial nephrectomy, a surgery with significant comorbidity, DCMP due to chemotherapy, large LV clot with IVC thrombosis. So for that we plan the anesthesia 3 phases. First we initially for 1 week we plan preoperatively, then intraoperatively, and then postoperatively. In the preoperatively, we first examine the patient about 10 days before the plan of the surgery, and that type patient has 3 significant finding of the LV failure and some infection. So that was treated in the 10-day process, and from the cardiac side, the all medication was started, and that all the features of the heart failure and infection get controlled before the surgery. And in the period at that time also the pediatric nephrology prophylactic consent was taken. I already discussed with previous speaker. So for that, and second time child was evaluated 1 day prior to surgery, and at this time the main concern of evaluation was the any features suggestive of the heart failure or not. And for that already child is consoled by the different faculty, while nephrology, pediatric cardiology, pediatric surgery. So high concern was taken from the anesthesia point of view, from the major cardiac adverse effect, need of post-operative mechanical ventilation, and their need of their consequences, and SDU or ICU were arranged, and collection was withhold nearly 1 day prior to surgery, and then switch to the heparin, because the controlling the heparin is easier compared to collection. And for the next day, for the day of the surgery, patient asked to take all the medication excepting the enalapril, and morning left light and HPT and PTNI were sent, and NPO was a standard protocol was asked. And just 1 day before the surgery, all investigation was normal excepting the low normal HB. Other things are normal. So on the day of surgery, the child was pre-medicated before the OT with the fentanyl and midazolam, and then when the child became calm, then shifted to the OT. After in the OT, all the standard monitor for ECG, SpO2, and IPP, defibrillator pad was attached because it is high risk of perioperative, intraoperative arrhythmia and cardiac arrest. So it was attached, and child was gradually induced with the high dose of fentanyl. 4 max, usually we use the 2 max, but in this case, with cardiac condition, we use 4 max with etomidat and etrapedium. And child was intubated with the 4 endotracheal tube. And after intubation and securing the airway, the left radial artery of the child was cannulated for the continuous hemodynamic monitoring and frequent ABG during intraoperative period. And after the securing the ABG, first baseline ABG was taken for the hematocrit, lactate, and electrolyte. After securing the left radial artery, the right IJV was scanned because from the nephrology side, the plan was the patient may need hemodialysis post-operative. And that case, they want to 7 French of hemodialysis catheter, which usually in the pediatric we put the 4 or 5 French. 7 French usually we not put it. And this is the small child also 20 months, 8.5 kg. So we after the GA, controlling the environment, we scan the internal jugular. We are scanning the internal jugular, see the internal diameter of the internal jugular, and see the outer diameter of the 7 French SD catheter, because usually we not do it. And then we compare both diameter. Usually the diameter is less than 50%. Exactly, this child has 50% of the diameter of the internal diameter, outer diameter of the 7 French is 50% of the internal diameter of the IJV. So there is no issue in the post-operative, intraoperative, the venous flow impedance in the right IJV. After securing the right IJV with hemodialysis catheter, that intraoperative we use the central venous line, and so that we started dovitamin and norlin as a prophylactic, because this is the low cardiac output, and all anesthetic agent, most of the anesthetic agent has some amount of cardiac depression. whatever the so-called cardiac shift, even that anesthesia was also has some cardiac depression. So for that we started dovitamin and noradrenaline. Dovitamin to keep the heart rate at least normal to the child, whatever the in the preoperative condition, and the noradrenaline to maintain the SVR, because we also not want to get the SVR down. And anesthesia was maintained with the standard oxygen, air, and isoflurane, and intermittent dosage of etraquinone was given for the relaxation. And anesthesia was planned with the caudal and IV intermittent bolus with the fentanyl. So intraoperative hemodynamics was nearly maintained, and with the help of the colloid, blood and blood product, and vasopressor and dovitamin. During intraoperative, the two major events will happen of the hypertension, significant hypertension. The BP goes to the 50/20. Both one, but the exhumed, because that time the surgeon was clamping the IVC. So he already asked to, I am going to clamp the IVC. So that time we give some bolus of the fluid, because we not give much, because LV is already compromised, and we increase the dose of the vasopressor and inotrope. And they successfully tied over that time, and after when they release the clamp, at that time due to acidosis, again patient had hypertension, but that time the bicarbonate goes to 30. So that time we give the 1 mg per kg, but even bicarbonate bolus. Then the BP become and hemodynamic become normal. Then surgery was uneventful. At the end, nearly blood loss was 300 ml, and all the patients were done judiciously with the 200 ml RBC and 80 ml of FFP, apart from the normal crystal and colloid. So you can see that this chart, the only two places you see the hypertension, one place here and one place here, and these both places are known. So in the post-operative, the child was shifted intubated because of major surgery, and at that time patient had metabolic acidosis and lactate was nearly 5. So patient was kept intubated, sedated and paralyzed. And ABG was repeated after half an hour of the shifting the SDU, and after again repeated 2 hours, and that after 2 hours the metabolic parameter get improved. So then relaxation was reversed and sedation was gradually tapered, and child was extubated on the same day at late evening. And post-operative anesthesia was maintained with the fentanyl infusion and paracetamol, because we should not use any NSAID. Thank you.
Once the anesthetic concerns were addressed, we had planned for surgical excision of the tumor, and a right transverse supraumbilical incision was given. We can see that the incision is above the umbilicus, and once we had entered the peritoneal cavity, the colon and the bowel loops were reflected medially, and this is the right kidney which is replaced entirely by the tumor, and there were 2 renal veins which were noted, and there was a tumor thrombus which was noted within the renal vein, which was an intraoperative surprise for us as it was not clearly delineated on the preoperative scans. And prior to excision of the thrombus, we had to secure control over the IVC, that is, a sling was placed above and below the level of the tumor thrombus, and even the left contralateral renal vein which is draining into the IVC was also secured. So this is the right renal vein, this is the lower one, and this is the upper renal vein, and this is the sling which was placed around the IVC. And once the control was established, the venotomy was done and the tumor thrombus was excised in toto, and later the IVC was repaired. Following after that, we had handled the upper renal vein thrombus, which was again excised in toto, but the tumor thrombus here was adherent to the vessel wall, so we had to go ahead with a sharp dissection. And the nephrourectomy was then completed. Following completion of the right-sided nephrourectomy, we had confirmed with the anesthesia team that the child was stable hemodynamically, and then we had planned for a left-sided tumor excision. The incision was extended onto the left side, and as we can see, the colon was again reflected medially, and this is the spleen, and tumor was noted at the upper pole of the kidney. This is the post-nephron sparing surgery picture, and the upper pole of the kidney was excised, the entire tumor was removed, and the open calyx was then closed over a DG stent. And there was slight bluish discoloration over the mid and lower pole of the kidney, which improved after local application of papaverine. The immediate postoperative period of the child was uneventful. She had urine output from the drain which decreased and the drain was removed on post-op day 5. I would now request Dr. Nayan Krishna from pathology to discuss the histopath report.
Good afternoon. I'll be discussing the histopathology part. We received the right kidney. On serial slicing of the right kidney, we observe a fleshy tumor, solid and cystic, and which is extending into the whole of the kidney. The renal sinus and pelvis cannot be identified. On serial slicing of the left kidney, we again see a fleshy, lobulated, solid tumor, which is extending into the whole of the kidney. So on histopathological examination of the right kidney, the viable tumor was 25%. There was a chemotherapy-induced change of 75%, 8% blastomal component, 37% epithelial component, and 55% stromal component. Here we can see the blastomal component and the stromal components. Higher magnification of the blastomal component here. This is the epithelial component, which in higher magnification we can see this tubule formation. The stromal component, and also there were a foci of dystrophic calcification. We saw some areas of squamous metaplasia, and along with that some rhabdomyoblastic differentiation also, which is a chemotherapy induced change. On the examination of the left kidney sections, the viable tumor was seen in 30% of the total area. 70% chemotherapy induced change was seen, 37% blastomal component, 52% epithelial, and 11% stromal component. This is the blastomal component. We can see here the blastomal cells in higher magnification. The epithelial component forming gland-like arrangement. Stromal component comprising of rhabdomyoblastic differentiation, which is again the chemotherapy induced change. So based on these features, because the chemotherapy induced change was more than 66%, you can say that this is a regressive type of tumor. So the final diagnosis is Wilms tumor, post-chemotherapy regressive type in bilateral kidneys, which is intermediate risk according to International Society of Pediatric Oncology. For bilateral kidneys, bilateral Wilms, the stage is 5. The right kidney is stage 3.
On follow-up, the child had received adriamycin-free chemotherapy and radiotherapy was not given to avoid damage to the residual renal parenchyma and also in view of cardiotoxicity. And the child was asymptomatic at follow-up. Her BP recordings have normalized, and ultrasound and CECT, which was done recently, showed no evidence of recurrence. And the renal function tests are also normal, creatinine is 0.3. And the postoperative RDS scan was suggestive of functioning left kidney with non-obstructive clearance, and the GFR was 75. And cardiac evaluation, which was already discussed by Dr. Nabil, had revealed an improving trend in the left ventricular ejection fraction, and the left ventricular clot has also improved. I would now like to request Dr. Nillai to carry forward the discussion.
So I'll just conclude by saying that it's a very rare case. We have just mentioned the incidence that how frequent is the bilateral Wilms tumor, how frequent is the IVC thrombus and cardiotoxicity. So if you combine all these three together, you will realize that the chances of getting all the three things in a single patient is less than 1 in 10,000 Wilms tumor cases. So this combination is extremely rare. I don't think we have found anything such in literature. We only have experience of treating one Wilms tumor with bilateral Wilms tumor with the IVC thrombus, and that patient did not respond well to chemotherapy. And apart from this rarity, it highlights the importance of the team approach, that so many departments were involved in the end to secure success in such a rare patient, such a rare case. So this is highlighting that how we can, what we can achieve if we work together. And surgically, it was very challenging because we were facing the wall because this is a patient who had very low cardiac output. So intraoperatively, we saw its IVC thrombus fine. We started dissecting. Then we found another renal vein, another IVC thrombus. So for us, it was a challenging case surgically also, and it's a very rare case. So open to comments. Thank you.
Yeah, because obviously we have very kidney left only. What is that taking to retard the pace of further injury?
So, sir, this patient currently doesn't have proteinuria, so he's been regularly seen by pediatric nephrology right now. He's already on ACE inhibitors, which are recommended in such cases, and the blood pressure is in the control, and we'll keep the child on follow for the same. That's a very good question right now. See, so if we see management per se, it doesn't make a difference. But these patients are likely to have germline mutations. So if you want to prognosticate their close relatives, whether they want to go for screening or not, it can be recommended, but currently it's not a part of the routine protocol for investigation right now. But as we are getting more comfortable with genomics, we are seeing a future probably there we will get this testing not only for the treatment and prognosis per se, but also to see patients who may develop cardiotoxicity. It doesn't have assembly right now, but definitely we can also investigate for close relatives if we get a analysis done.
Not want to look at WT1 here.
That WT1, if we the thing is, what benefit do we get? So, had this patient been a patient who doesn't have a WIMS tumor, so WT1 would have been effective in prognosticating. But if we see, we got the biopsy, which was by mistake mentioned as a whole kidney on the left side, but it also had a 1 centimeter parenchyma. That kidney was also not showing any areas of nephrogenic rest. So the chances of this patient, and so we expect no difference in the management of this patient first if we take the index case, whether he has a WT1 mutation or not right now. But definitely want to prognosticate and talk about the family and the recurrence and the other things in the family. It definitely has importance.
What about Dennis rash or something? You know that could this be Dennis rash still?
So Dennis rash against this that generally as normal, which is abnormal in.
Okay, you know, you may not always have.
Okay, sir. Sir, Dennis rash, even if it's Dennis rash, the thing is our management won't change by any means because we are better than tumor and rest will be managed by you.
Yeah.
Yes, sir, please. Sir, from our experience, what I'll report, so we had published our experience of roughly 10 cases. It's very rare, so over 11 years we had 10 cases. And we noticed if we perform a partial nephrectomy, then there's no recurrence. But sometimes we have to perform a tumorectomy because there's not enough space available to do a partial nephrectomy. So once we did that, we noticed we had a 50% recurrence rate. So that talks about the margins right now. But if we talk about the chances of a metachronous development in another part of the kidney, so because the nephrogenic rests are absent and anyway we'll keep this patient in follow-up, the chances are a bit low. Yes, please. Please come again, sir. Margins, because there was 1 centimeter area of normal kidney which did not have any nephrogenic rest. Yes, ma'am.
Not very high. What was happening here? So, was there any evidence of microarteries or any biomarkers done what triggered the cardiac dysfunction as structural doses? So, he continues to have low cardiac function.
Ma'am, actually, we got a Pete's cardio opinion, so this is how far the surgeon thinks. So, probably Dr. Nabil can answer this question. Yes, exactly, ma'am. This patient only got 60. Yes, this patient only got 60 milligram per meter square of dose, which is pretty less. This will probably, one thing by noticing, probably you can change your practice is although the efficacy is not proven, is liposomal. Yes, because it's not very costly, and I think we are too much cost cutting right now. Probably we can start using these drugs, which are shown to be probably, although the benefit is not clear, but probably they can be more better in reducing cardiotoxicity.
Ma'am, I can tell you something about that. If there is cardiotoxicity based on that cumulative dosage is mostly based on the adult studies where they have published literature. But in pediatric age group, most of them they are defining the age group less than 5 years as a risk factor as such. And there are several cases where they are published where they have given a very low dose, single dose, and the patient has developed cardiotoxicity. So we cannot go by dose in pediatric age.
Sorry, please come again.
This patient, right, he was completely.
But he had a normal GFR. Normal GFR perioperative, 117 around. Yeah. I think genetics will answer this. Why did this patient develop cardiotoxicity? We had some slides, but sorry, we took too much time.
The question from